Daniel Lowenstein, Senior Director, Public Affairs, Primary Care Development Corporation.
Okay, thank you very much. Chair people and vice chairs and ranking members of the legislature. I'm going to take less than 10 minutes. I'm going to probably take less than 5, which is only slightly less than your average primary care visit. We're trying to change that. As I said, I'm a Senior Director of Public Affairs for PCDC, the Primary Care Development Corporation. We are a nonprofit that works to expand access to primary care in underserved communities. We provide affordable capital to expand primary care. We provide expert technical assistance to change the primary care model. And we provide advocacy to really support policies and funding that support and sustain the primary care sector. Overall, we have had investments of about $670 million in primary care projects that have provided access to primary care to 860,000 new patients. We've trained thousands of workers and hundreds of organizations, including 200 patient-centered medical homes that have been recently transformed. Primary care really is the linchpin of healthcare delivery and payment reform because of its proven ability to improve health while lowering costs. And we do support the New York State agenda of DSRIP, the State Health Innovation Plan, value-based payments, which are really working to transform the system. Primary care is at the heart of that system, but it must be funded and there must be strong policies that support it. Right now, about 5 to 8% of total spending is on primary care. This despite the fact that primary care, more people use primary care than any other healthcare service. Here's our priorities. Number 1, capital for community-based healthcare providers who were largely left out of the funding last year and in previous years. We are asking for $20 million for the Community Healthcare Revolving Capital Fund, which we were very grateful was supported last year in the budget. There was $19.5 million. We think that can be utilized very quickly, and we're looking for another 20. We're looking for 25% of the Healthcare Facilities Transformation Program to be targeted to community-based healthcare providers, and 25% of the essential healthcare provider appropriation also for community-based providers. Number 2, to restore and increase funding for PCDC to $600,000. We're very grateful to the legislature, which has restored this money over the last number of years. We use it to really help the primary care sectors and individual providers in this increasingly complex environment. Number 3, provide $54.4 million in contingency funds to make up for the potential lost funding in the Diagnostic and Treatment Center Uncompensated Care Pool. This is the item that the Community Healthcare Association of New York State advocated for. We fully support the request. It is important to the stability of the sector. Number 4, we support the language regulating retail clinics to ensure greater integration with primary care. And number 5, just regarding the minimum wage, we know that frontline workers who work directly with patients and who work in our communities are absolutely essential to this transform model. They are the ones who are going to be coordinating the care. They are the ones who are going to take the higher costs out of the system. A recent report by PCDC and 1199 SEIU found that about 3/4 of providers were having trouble retaining these types of staff, and about half of the reason for about half was insufficient salary. But we also know that this money is not something that they have hanging around. These providers have to be funded in order to support these essential workers in the healthcare system. Thank you.
Thank you very much. Questions? Yes.
Thank you.
Senator
Hi.
Krueger.
Very quickly. Your definition of a retail care center, is that what we call an urgent care and emergency care center?
No, urgent care is a different definition, is our understanding. This is retail within the confines of a retail establishment. So it's more like a CVS with a clinic.
Got it. Okay. So.
Senator Bileski has a question, please.
Oh, no, I had one more. I'm sorry.
I'm sorry.
Sorry, Senator
Go ahead,
Bileski.
Senator Krueger.
And the integration of primary care with alcohol and substance abuse.
Yes.
I thought when they moved to Article 28, that was their intention. That's what they were going to do, provide primary care at the site. They were also providing substance abuse treatment. That's not the case?
So my understanding is that the integration is That provision in the budget does is it gives them access to a DASNY financing pool for alcohol and substance abuse providers to make sure that even though they are going to have an Article 28 also, they can still have access to that pool of money, which is fully within, we completely support that.
Thank you.
Thank you. Senator Valesky?
Thank you, Madam Chair. Thank you, Dan. Very, very quickly, just one point. Both Haney's and the Iroquois Healthcare Alliance in their presentation earlier today in regards to access to primary care, both referred to the Doctors Across New York program. I noticed in your testimony, in your 5 points, that you don't speak to that program. Do you have a thought on Doctors Across New York in terms of its effectiveness? It
was more of a matter of, yes, we fully support it, very much so, yeah.
It just didn't make the cut
yes,
in terms of the
yes.
top 5. Okay,
Yeah.
all right, thank you.
Thank you.
Thank you.
Thank you.
Thank you.
Brian O'Malley, Executive Director, Consumer Directed Personal Assistance Association of New York State.
Hi, good evening. I'm going to try and be brief. We have a number of programs that would help mitigate costs and strengthen protections, but I do want to focus on just 3 primary ones this evening. I do thank you for taking the time to hear from us. For those who don't know, the Consumer Directed Personal Assistance Association of New York State represents the nearly 15,000 New Yorkers with disabilities and chronic health needs who use the Consumer Directed Personal Assistance Program, where they can recruit, hire, supervise, and if necessary, terminate their own workers. These workers can be anyone except a spouse or parent. And actually that latter one will change in April due to legislation passed last year. Our consumers employ approximately 30,000 workers across the state. It's one of the fastest growing areas of the home care industry, which in and of itself is one of the fastest growing sectors of the employment of the current economy. Overall, from our perspective, there's actually very little to like about this budget. The largest problem with it is the fact that the governor, as you've already heard, has proposed dramatic increases in the minimum wage without honoring the state's obligation to fund those increases through the Medicaid program. To be clear, our program is 100% Medicaid. We do not exist outside of the world of Medicaid. We cannot raise the cost of a t-shirt. We cannot raise the cost of a hamburger. We cannot buttress these costs in a private pay marketplace. If the minimum wage increase is not funded, then the program goes out of business. This hits hardest in the southern tier and central New York, where there's about 4 to 5 million of unaccounted for costs, and in New York City, where there's about 30 million of unaccounted for costs. This is in year 1 only. These costs are truly layered on top of a system that has already degraded reimbursement to a point where fiscal intermediaries, those are the providers, cannot add 1 penny to the cost of providing direct services. In an ironic twist, many of my members have commented that they could dramatically increase their reimbursement by doing such things as purchasing company cars or increasing expense accounts. However, as good stewards of taxpayer dollars committed to the services they provide, this is not the course of action they choose. In fact, most of my members have about an 8 to 12% administrative cost, with 88 to 92% of each dollar going to providing direct services. The fact that the direct care costs are insufficient has led to what is already an all-time low in funding for these organizations, with the average funding being less today than it was in 2006, not adjusting for inflation. There's no more fat to trim. There's no more efficiencies to find. The failure to fund this minimum wage increase and adequately fund this program is causing the entire program to collapse upon itself. CD Paney's is not worried that one or two FIs will have to close their door. We're discussing the potential wholesale collapse of an industry. FIs in New York City, sorry, this is the problem with jumping around in your testimony. CDPA is integral to the state's efforts to achieve the triple aim. Delivering high-quality services for less money with higher consumer satisfaction, CDPA allows the state to lower cost. It's estimated that we saved the state Medicaid program over $50 million just last year. That's expected to grow exponentially this year as the program has increased by 40% in the last year due to managed care. The budget undermines all of that by ignoring a simple financial truth, that services cannot be delivered if the money is not there to pay for them. The governor noted that the failure to pay a minimum wage, that is a living wage, amounted to nothing more than a subsidy for employers. He stressed that it costs $6,800 per year in public subsidies to keep a McDonald's or Burger King employee at the current minimum wage. What he fails to note is that the current worker in the Medicaid system who receives a minimum wage because that is what the state's inadequate reimbursement allows also costs the state $6,800 per year in public subsidies. What he fails to mention is that the accomplishment of his global cap and reining in Medicaid growth has come on the back of the working poor, often single mothers. These workers do backbreaking work and cannot afford to put food on the table for their family or heat their home without benefits and subsidies from TANF, HEAP, and other social safety nets. In other words, while the governor decried McDonald's and Burger King for using public benefits to lower their bottom line, his Medicaid program is doing just that. Last year, Governor Cuomo, acknowledging the distinct differences in CDPA from other traditional services, committed to fully funding the program's costs incurred as a result of the new federal rules that require full overtime to be paid, as well as travel costs. He committed to doing this in consumer-directed because he acknowledged that we have no control over where consumers hire, over who consumers hire, and how long they scheduled them for. He promised $20 million to fund overtime last year. His ultimate solution of 34 cents an hour would deliver $10 million to this program, a 50% cut. He has proposed that same number on an annualized basis this year, meaning that this year's proposal is a 50% cut from what was promised and passed in the budget last year for overtime and travel in consumer-directed. This is an enormous problem that, again, threatens the stability of this program. Many workers have subsidized inadequate wages by working 60 or 70 hours a week, and they cannot afford to take these pay cuts. Finally, I want to promote the certification of fiscal intermediaries. This is legislation sponsored by Senator Hannan and Assemblyman Gottfried that the legislature passed unanimously last year. For some reason, it was vetoed by the governor. He purported that it had outrageous fiscal costs, but was very important. Despite his feeling that it was important, the legislature's obvious feeling that it was important, and any number of organizations that felt it was important, he did not include it in his budget. We feel it is imperative that the legislature again address this issue and put it in the budget this year to make sure that fiscal intermediaries operating in consumer-directed are not merely operating scofflaw home care programs and are in fact running a consumer-directed personal assistance program. With that, I'm available for questions, and we'll be in to see all of you. Thank you.
Question, any questions?
One question.
Sir?
Yes.
Sir, Senator Kruger?
Thank you. So, I know we made you skip around, but is there a definition of a scofflaw program versus an approved program?
So in consumer-directed, we would argue that many agencies, traditional licensed agencies, are merely taking what were their personal care aides and pulling them into a now consumer-directed case where that consumer is not hiring. For instance, we had one worker call who said she was brought in to work for 2 different consumers who she never met prior to the day she went in. She's now doing nursing tasks, which is well outside the scope of what a PCA can do. The agency is still scheduling her, not the consumers. In fact, the one consumer will not even allow her to touch them, which makes you wonder what they're billing Medicaid for. But this is what we're talking about in terms of scofflaw. It's individuals acting outside their scope of what they're allowed to do.
So if I understand it right, consumer-directed is a lower cost reimbursement, so why would an agency in home care business create a fake consumer-directed subsidiary or within their own agency?
Largely, managed care companies are increasingly driving more and more individuals to consumer-directed. More and more individuals are identifying consumer-directed as a means in which, as a platform they want to pursue. And particularly downstate, consumer-directed is not subject to the wage parity laws. And so agencies can get out of paying their workers wage parity in the wage parity counties.
I knew there was something like that there. Thank you very much.
Thank you, Brian.
Thank you.
Thank you.
Empire Justice Center, Amy Lowenstein, Senior Attorney. No, I skipped one.
Good evening. Thank you for staying so late. And thank you for the opportunity to testify. I've shortened, first of all, don't worry, it's large print. It's not as big as it looks. I just want to touch on a few points. I know some of my colleagues at the Schuyler Center, Medicaid Matters, and Healthcare for All New York will also touch on in more detail. And then I want to just go into a little more detail on some things that I don't believe anybody has addressed, or at least from a consumer perspective. So Empire Justice Center is a statewide legal assistance organization with offices in 4 cities, including Albany. We focus on issues that affect low-income families, and healthcare and access to healthcare is one of our critical programs. My testimony details the work we've done in the area of healthcare over the years and the committees and work groups we're on. I will not get into that. So the first thing I want to talk about is our request to expand the Community Health Advocates Program and support that program. We appreciate the governor's continued support for community health advocates, also called CHA. This is the 1H CHA, not the 2H CHA, through $2.5 million allocation in the executive budget. But we're still seeking from the legislature, once again, additional funds for CHA to bring it to its current annualized budget of $4 million. This will allow the program to continue providing the same level of services, and without this investment, CHA is going to face a 25% reduction across the board. So quickly, Community Health Advocates is a statewide network of community-based organizations, including chambers of commerce that assist individuals and small employers so that they're able to effectively use the health insurance that they have now attained. We also do help people who don't have insurance, who are finding themselves with bills, figuring out how they can get coverage for those bills. And that's briefly, I'm not going to get into any more detail on that, but the requests we're making.
No, you're getting it in a minute.
Okay, all right. I'm reading something that says Schuyler Center, and
Yeah,
I'm going,
no.
that's funny, you don't look like Bridget. Yeah, sorry.
Some of it's similar, but
No.
I don't think that's going to help you.
I jumped it, actually.
Okay, so once you have it, I won't reference it until you have
Yeah,
it.
here it is.
You're fine.
Okay.
I'm the one that's in problems.
Sorry, I didn't know it was you.
Reading backwards.
So anyway, just to sum up, we're seeking an investment. Last year, the legislature, the Assembly put in $500,000 for CHA to bring it to $3 million. We're asking for $1.5 million because our budget has now been annualized to $4 million. Quickly, to touch on a few issues, we ask that the legislature ensure that sick and disabled children, New Yorkers with disabilities, and seniors continue to have access to medically necessary care by preserving spousal and parental refusal in the Medicaid program. We also ask that the prescriber prevails provisions in fee-for-service Medicaid and Medicaid managed care be preserved as well, so that providers who are really working with people with multiple conditions are able to make the choices about what is best for their patients. Quickly, there's some proposed changes to MLTC, putting in a nursing home level of care requirement. We are asking the legislature to consider this cautiously, because if this means a smaller number of people going on to MLTC, it means more people going back to the local districts to get their care. And already we're hearing from local districts that they're having trouble meeting the home care needs of people over whom they still retain responsibility. Like our colleagues in the provider community, we're concerned about the cross-claim issue between Medicaid and Medicare. Last year, it was done for Part B so that the amount of the co-insurance that Medicaid would pay was reduced. We've seen the impact on our clients. I have one story in here, and we don't want to see it happening even further, because what it means is people will lose access to providers. Providers won't want to see people who are dually eligible. I mean, not all of them, of course. So I wanted to get into a little more detail, but I promise not too much. We're calling, along with our colleagues at Medicaid Matters, Schuyler Center, and Healthcare for All New York, for an expansion of the Essential program to cover all immigrants who are permanently residing under color of law. The Basic Health program has been renamed the Essential Plan, and it launched on January 1st. We think of it as a huge step forward in making health insurance much more affordable for people who are just above the Medicaid income threshold. But while it promises affordable health insurance to many low-income New Yorkers, there is a subset of people who are permanently residing under color of law, including people who are deferred action for childhood arrival, who are left out of the Essential Plan. These individuals are eligible for Medicaid, but once their income goes above the Medicaid level, they basically have a health insurance cliff. They are not allowed to enroll in the Essential Plan. They're not allowed to enroll in any marketplace products. There are no affordable health insurance options for them because of certain federal rules. So what we're asking, and instead of having insurance, people forego treatment, or they seek out care only in emergencies, and they wind up using the quote-unquote charity care system in hospitals. So we're asking the legislature to ensure access to this population. Community Service Society is going to come up with a study, and they have a study. It's going to be published very shortly, I think in the next week, that says it's about 5,500 people who are affected, and that the cost to the state would be $10.3 million. And it would create basically a state-funded Essential Plan. Something that came up very briefly in the beginning of this long day was the reduction in the spousal impoverishment resource allowance. And I don't think anyone really touched on it, but basically 20 years ago, New York State set the resource allowance at just below $75,000. That amount has never been adjusted. And this year, what is being proposed is reducing that amount by $50,000. So these are the resources that a community spouse of somebody who's in a nursing home, a waiver program, or managed long-term care, these are the resources that they are able to keep. Those who benefit from spousal impoverishment are usually on fixed incomes, and they're using their income and spending down their resources to pay the cost of their living expenses, including their own medical bills. It helps stave off their need to rely on Medicaid. So I don't know if you have my testimony, but if you look on page 7, I actually put in a chart. This is courtesy of New York Legal Assistance Group. But there's a formula under federal law for how you figure out what resources can be retained by the well or community spouse. And it's the federal minimum allowance or whatever the state sets, so that's just below $75,000 in New York, or 1/2 of the couple's combined assets up to $119,000, whichever is higher. So already in New York, we have a situation where people who have more resources get to have a higher resource limit than people with lower resources. This morning it was said that the reason for this proposal is to ensure that the people who need it most are the only ones getting access to the spousal impoverishment protections. This will do the opposite. People who have the lower resources will actually be able to keep less, while people with higher resources will be able to retain the same amounts they can currently. So we are actually asking for New York to up its spousal resource allowance to the federal maximum, which would put everybody on the same level. And I couldn't find updated data in time, but in an AARP study of states in 2010, there were 18 states that used the federal maximum. Okay, the last thing two quick things I want to touch on is addressing barriers to care that we're seeing in home care. And we've moved to managed long-term care, and Medicaid managed care is the primary source for obtaining home care. However, we, as a legal office, have seen a huge amount of people having trouble accessing care. There's an aid shortage upstate. We hear from local districts and managed care plans that they just can't fill hours that they've approved. We have fair hearing decisions saying that the plans or the local district have to comply with the number of hours they've approved, and we're still not able to get the care in. We are also concerned that managed care plans are discouraging people with higher needs from enrolling by offering insufficient number of hours, requiring people to have a backup from a family member, telling people that their needs are too high before actually assessing them, and telling them that they don't provide 24-hour care, which is not permissible. We've also seen widespread across-the-board reductions in hours by some plans, and when those cases are taken to hearing, they are almost always overturned. So we have some recommendations. My colleague Lara Castle is actually going to touch on those in order to address that. The last thing I want to quickly say is, and I'm not going to go into detail, we have been looking at fair hearing decisions and talking to clients, and we think it's the 4-year experiment on a physical therapy, occupational therapy, and speech therapy cap of 20 visits has failed. We have people who are foregoing, who are unable to get the physical therapy they need after surgeries, after accidents. People who we have a client who uses maintenance therapy. She uses up her 20 visits. Every year she basically deteriorates, and then she has to start up all over again. And so we're asking the legislature to reconsider that and repeal the cap. Thank you.
Thank you very much. Any questions? One question.
Does the 20-visit cap, does that apply to people with developmental disabilities as well? Or is this just...
There are some, I don't know the exceptions off the top of my head. It depends on where they're getting the services. So there are some clinics where it doesn't apply. And it doesn't apply to people who have TBIs. But it applies to, anybody who's getting physical therapy, occupational therapy, or speech therapy in an outpatient setting, other than sort of clinics that have certain licenses.
So you might have somebody with autism or something like that. Does it apply to them?
Sorry?
Does it apply to people, let's say, with autism or something like that?
Well, it doesn't apply to children, for starters. Right. I think that the waiver programs have, and this is something that my colleagues who do the waiver programs know a little better than me, so I'm going to admit to not being great on this one, that there are certain clinic environments where it can be done for people who are in waiver programs.
Because I thought our statute was a monetary, not a visit cap.
No, our statute is a visit cap. So the hearing officers will say, there's no doubt that you need this physical therapy. However, you already had 20. And I mean, there's hundreds of fair hearing decisions like this.
Okay, thank you.
Thank you.
Yes. And I can get you additional information on that as well, on who is covered and who's not.
I think it's relevant because the the proposal was for insurance companies to pick up more on early intervention, for example. That seems to be contrary to this concept here of you want people to get better or to maintain at a level where they can function.
Right, it is. I mean, the earlier intervention, it wouldn't apply to our statute doesn't apply to children, so
right,
they are sort of say the safe harbor.
I'm just saying consistency. In one place, we're trying to get insurance companies to cover more, and here we don't seem to be caring at all whether they cover at this end.
Right, yes.
Okay,
and
thank you.
In the commercial setting, you can actually get far more.
Thank you.
Thank you very much.